Hello, my name is David Sonsky. I'm a fourth-year medical student here at the University of Toledo College of Medicine. Today I would like to share with you my experiences on the Orthopaedics Acting Internship. Specifically, I would like to share with you my time spent with Dr. Ebraheim, a renowned trauma surgeon here at the university. We saw a wide bevy of cases, including some truly unique and remarkable patients. Furthermore, I would like to elaborate on some of these cases as well as our time shared on the service.
At the University of Toledo, Dr. Ebraheim always puts emphasis on education. Whether it's medical students or residents, he will meet them at their level of training and teach them through conferences, lectures, as well as just questions, making sure that they have a good understanding of whatever it is the content that they're covering. During medical student lectures, we cover a wide variety of topics. Typically, these stem from Dr. Ebraheim's Trauma Handbook, which is a medical student handbook covering some very high-yield topics that will typically come up in residency interviews, as well as certainly throughout your rotations. At the University of Toledo, we put emphasis on basic science. Osteoblasts are a single nucleated molecule which promote bone growth. Additionally, they secrete a third-party molecule called rank L. This stimulates osteoclast activity. Osteoclasts are multinucleated cells which degrade bone. Furthermore, osteoblasts stimulate the release of another third-party molecule called osteoproteogerin. This inhibits osteoclast activity and is responsible for the meticulous balance of bone remodeling. This is an intricate process controlled by osteoblasts. Students can expect to play a very active clinical role. Students will see patients independently, do a physical exam, come up with a differential, and then a diagnosis, a workup, and a treatment plan. They will present this to the attending physician, and they will also have a role in procedures. Under close attending supervision, students will be able to inject, cast, splint, they will be able to remove sutures, and they will also be expected to know the basics of imaging, whether that's reading x-rays, MRIs, and CT scans. On this rotation, students will be involved with a lot of injections. Some of the more challenging injections can be done under the guidance of ultrasound. Dr. Ebraheim will frequently inject both SI joint as well as shoulders. Students can expect to see a wide variety of cases, including both fractures as well as dislocations. Additionally, students should be able to set the room. They should be able to come up with the best surgical technique. And by that I mean, if there's a minimally invasive technique available, they should understand why that would be advantageous and which one to use. Furthermore, students should know how to decipher what imaging is best, what views, and how to go about the case with the fewest x-rays and scans as possible, limiting the radiation and providing the best outcome down the road. At the University of Toledo, our goal is always to give the patient an optimal chance at recovery. So to do this, we typically will use minimally invasive techniques if they're applicable. When I was on my rotation, some of the cases we saw were patellar fractures, proximal humerus fractures treated with external fixator devices, terrible triads, minimal incision, submuscular fixations, and all of these with the goal of giving the patient the best chance of healing with the least chance of complications. During my time on the service, I saw many minimally invasive repairs. Just to speak to a couple, I saw several proximal humerus fractures. These, of course, are high risk for avascular necrosis. These were treated with external fixation devices, which cause minimal disruption of the periosteum and promote the best chance of bone healing. Additionally, I saw a patient with a patellar fracture. She had poor skin quality, which was not amenable to an open repair. So for her, percutaneous screws were used to fix this patellar fracture. She did quite well. Additionally, Dr. Ebraheim is well known for his minimally invasive ankle fracture fixation. I was fortunate enough to be able to see this technique, and again, the patient did very well. In combined radius ulnar fractures, Dr. Ebraheim emphasizes the importance of achieving radial bow. With good radial bow, this gives patients optimal chance of recovering both rotation as well as range of motion of the forearm. We find our strength in the sciences. To help internalize some of this content, Dr. Ebraheim has a plethora of mnemonics. One such example is this. First, God made the bone and everything attached to it, including tendons and ligaments. This is type 1 collagen. Then, God made cartilage, type 2 collagen. So in my experience, working with Dr. Ebraheim has been a lot like shopping at Costco. Bulk teaching, everything's related, and you're certainly getting a great deal. Furthermore, during my time, I have certainly improved my operative skill, my clinical skill, and my knowledge. So anyone interested in this rotation, I would highly recommend it. Thank you, and hopefully this was helpful.
Thank you for listening to my video today. For further information regarding a clerkship at the University of Toledo, please feel free to contact our clerkship coordinator at the link provided.